This is a recording of the Uropathology EQA scheme participants meeting, circulation AE. This circulation was discussed at the participants meeting at the Royal College of Pathologists on the 2nd of December 2022. We did record the meeting, but unfortunately there was no sound. So this is a run through of the cases with the scoring that occurred. So for this circulation, there were 415 returns for the about 88% of the registered participants, with trainees and overseas also returning responses. There were some exemptions: kidney 13, testes 3, prostate core and prostate non-core. There were no penile cases. As a result, the exemptions don't appear for these. So let's move on to the first case. This was a female of 25. We had a radical nephrectomy. The tumour was large at 150 millimeters with a pale rubbery cut surface. It was located in the mid-kidney. We've told the immunoprofile was PAX8 positive, pancytokeratin positive, WT1 and CD56. And the proliferation marker was greater than 70%, but it was negative for neuroendocrine markers, desmin and myogenin. And this is what the slide looked like. There were some tubular areas. Some dystrophic bone, and the very occasional mitosis, which was difficult to spot on this thick section, which was done digitally. A large number wanted a further opinion, but only 16 felt it was not suitable for the EQA. And people felt there was an epithelial predominant type. They would do a BRAF and CD57 and exclude a metanephric adenoma, though the Ki67 was very high. So the main differential diagnosis with these is a metanephric adenoma. And you can see that someone has clipped the area from the WHO book. So the metanephric adenoma do have BRAF mutations. And this is probably echoed by most people. There's a DGH pathologist. They felt that this was a case they would refer directly to a specialist. Having said that, 88% of the returns correctly identified this as a nephroblastoma. And on asking the audience how many had come across the nephroblastoma in the last 5 years, most people put their hands up. So this is indeed a rare tumor, but people do come across it. The critical history is the 25 age. Must be thinking about these in that age bracket. But obviously it should be referred to the pediatric colleagues for further investigation. Having said that, we've felt it could be scored, and that as the metanephric adenoma and metanephric adenofibroma with a big differential diagnosis, these should score half marks. And the renal cell NOS again was scored half marks. But these two morphologically were incorrect, or the immunoprofile was incorrect. The next one was a testis. We were told they had elevated AFP, LDH, and HCG, although the levels were not given. The tumor was a grade tumor, and we were provided with a large number of scanned immunoslides: AFP, HCG, MNF116, CD30, and OCT34. Some people would refer more blocks, immuno, but again, very few number not suitable for the EQA. This is what the tumor looked like. High grade, evidence of necrosis. There were some more looser areas, more typical for yolk sac, like this. And there were some better glandular structures, more in keeping with post-pubertal teratoma. CD30 confirmed they're positive in these areas of embryonal, OCT34. The beta HCG picked up a few of the syncytial giant cells, and the AFP was highlighting the areas of yolk sac, and the MNF highlighted the areas of more post-pubertal teratoma. So normally we would ask for the predominant tumor type. Unfortunately, we forgot to put that in the question. We've moved previous circulations had the option of a mixed germ cell tumor, and this was just used as a coverall, but we now have removed that diagnosis and it says mixed germ cell, predominantly X, Y, or Z. Some people still sticking to the old ways, and some people had far too busy to look at all the immunos and yolk sacs. Some people thought it was a choriocarcinoma, but we need both the 2 layers to call it choriocarcinoma, and this was just the syncytial cells. 83% felt it was predominantly embryonal. Embryonal carcinoma was felt to be correct as well. So any diagnosis with embryonal was felt to score 1, and the postpubertal type missed the high-grade component, which was the most significant. Another testis. This is somewhat more straightforward. Entire tumor is replaced by a multinoid solid yellow-white tumor, and no immunohistochemistry was provided. Quite a few people would do immuno, and this is what the tumor looked like. Sheets of cells, prominent nucleoli, a straightforward seminoma. But there were some areas in the background that have this appearance, which is also described in seminomas, that looks a little bit like sex cord stromal tumors. There was some rete invasion with some pagetoid spread. Some people wanted further blocks. Suitable. I'm not sure what this comment was referring to. Some people spotted the stromal invasion of the rete testis. Some people would do immuno. 98% thought it was a seminoma. Diagnosis mentioning seminoma was scored half marks because there was no other component in this, and the others were deemed incorrect. AE4, this is a partial cystectomy. We're told a polypoid lesion underlying bladder. It was in the dome, but no immunohistochemistry was provided. And this is what it looked like. So you can see the large amount of tumor is actually in the lumen of the bladder, but this tumor seems to be spreading up this area here, and here at this power you can see that there's probably urachal remnants. The tumor shows this high-grade adenocarcinoma with some mucinous areas and the urachal remnant at the top. It's demonstrated here. Some people wanted immuno, some people further opinion. And the problem with this case was mainly the fact that the drop-down box had many options. And some people were querying it was a urachal carcinoma. Others felt that there was more in the lumen than there was in the urachus, and there was a diverticulum in the dome. Others felt it was more that. Using beta-catenin to exclude a metastatic disease, people were worried that it could be metastasis, and obviously would correlate it with radiology. And people would do further blocks. And here are the diagnostic criteria for urachal carcinoma from the WHO recent publication. And you can see absence of carcinoma in situ elsewhere in the bladder, extensive cystitis glandularis, and due to the sort of discrepancies in the morphology and the drop-down boxes, it was felt that all adenocarcinomas were correct. Urachal carcinoma is a type of adenocarcinoma. Again, it just shows the confusion around this area, but we felt that urothelial carcinoma was incorrect. And this, noting that this has been staged using the bladder staging, there's a specific staging system for urachal carcinomas, if it was indeed a urachal carcinoma. The next case was non-functioning kidney. We're told that extensive dilatation of the whole of the pelvic calyceal system filled with pus. No mass lesions, no immuno was done. It shows these areas, zonal areas of necrosis and inflammation, foci of calcification, and this rather purple area here, And there were sheets of histiocytes with neutrophils mixed in, occasional giant cells, and some inflammation spreading into the perinephric fat. Some people thought that this could be actinomyces-like areas or fungal, and sort of overlapping with the xanthogranulomatosis pyelonephritis. People would like to do a Pearls and a von Cossa. And this is the diagnosis which was given. And this is a sort of case which is difficult to score when the diagnosis offered is 6 lines long. And as a result, it was felt that everyone had called it an inflammatory process of one description or another, and it was deemed everyone to score a mark. The next case was a female of 71. We're told a right partial nephrectomy. We're told it's a tan brown lesion. It was negative for CK7, melan A, pancytokeratin, PAX8, HMB45, CD117, STAT6, EMA, BCL2, focally positive. We were provided with a macro image, CD34, and SMA and EM. This is what the tumor looked like, well circumscribed, yellowy brown tumor. These are the slides. Sheets of cells which look like this. And then some accentuation around vascular structures. The CD34 was strongly positive. The SMA showed patchy staining. And these rhomboid crystals were identified on the EM. A large number felt that it was not suitable for the EQA and would seek. And really, comments were really around the fact that they weren't sure what the EM showed, were these reading crystals, not suitable for the EQA. Some people weren't very impressed with the EM. These are rare renal tumors. And someone was thanked for submitting as no one has seen one of these before. And this is really reflected in the spread of diagnoses. But having said that, 87% had called it a juxtaglomerular cell tumor, which is correct. Immunohistochemistry for renin is available, but it was not performed in this case. On a show of hands in the audience, no one had diagnosed one of these tumors in the last 5 years. And as a result, even though there was high agreement in the diagnosis, it was felt to be a rare tumor and should not be scored. And here's the WHO, a snip from the WHO classification. And it describes variable reactivity for CD117 and SMA, negative for cytokeratins, as this one is. Rhomboid-shaped protogranule crystals, abundant, prominent Golgi. Oh, it's all there. So moving on to the next half, a 32-year-old male with a right testicular tumor. Tumor markers are negative, and he had underwent a right orchidectomy. Showed an area of poorly defined yellow-grey discoloration, and no immuno had been performed. And at low power, you can see that there's an area of fibrosis here, some normal testicular parenchyma, but the critical area is this area here on the slide, which is patchy inflammation. So there was no obvious germ cell neoplasia in situ, and areas of fibrosis here. But the critical areas showed vascular structures with fibrinoid necrosis. And there were 3 of these vessels showing this change. Some people wanted immuno, and that's not surprising considering the diagnoses that were offered. Some people thought they saw GCNIS, infarction and vasculitis. I would never make the diagnosis of regressed germ cell tumor. So I think people will miss the vasculitic process and we're concentrating on the area of scarring and considering this as a regressed tumor. And some person had saw a ischemic injury, but the cause was not apparent, although they'd obviously missed the vasculitis. And 60%, nearly 60% had spotted the vasculitis, whereas 30% had just gone for a testicular infarct. It was felt that combining these two will miss the fact that the testicular infarct would have missed the prospect that this was could have been a systemic disease. And given the fact that this was difficult to spot, some leniency was given as this digital slide, and the case was not scored. But it was a case of polyarteritis nodosa, necrotizing vasculitis. And it's interesting to note there are papers saying that this could mimic testicular torsion, and anchor should be tested. The next case was TURP, no previous urological history, 24 grams, representative sections taken. This is what it would look like. And this is a case which highlighted the problems with digital slides, that screening a large number of slides for novices to digital is time consuming, and that we shouldn't leave these EQA slides to the end and should try and do these as we go along. So there were large areas of granulomatous inflammation with areas of suppuration. Some people wanted further blocks, florid granulomatous, foci of necrosis, non-specific necrotizing granulomatous, difficult digital slide, unable to screen the whole slide, of course, ensures no subtle carcinoma, need glass. So I think this is on the edge of what we can expect people to do digitally. But 99.6% felt it was a granulomatous prostatitis, and a couple of people thought it was post-biopsy granuloma, but this wouldn't be as extensive. We were told there's no history of bladder cancer or BCG. Next case was a nephrouretectomy for a ureteric tumor. And this is what it looked like. So here's the ureter, surrounding fat, some patchy inflammation. You can see the muscle coat on this side, but it does not appear to be apparent on the other side. Here's the tumor, and it has a papillary high-grade appearance, and is shown to be infiltrating here. There's some muscle coat here with the tumor adjacent. So the problem was what we asked the stage, and if I just go back, actually, you can see there's some muscle coat here in the tumor, but the tumor seems to not penetrate further than the muscle coat. Although in some areas there was no obvious muscle coat present. And this is really what it was, the difference. People were worried there was PT2 or PT3. Some people would do some immunomarkers to look for neuroendocrine differentiation. Most people would do levels and a desmin. There was high agreement there's a urothelial carcinoma. Some people poorly differentiated. Interestingly, large nested came in, but this would have large nests of low-grade tumor, and this was infiltrating, angulated. This was felt with only half marks by the audience. Urachal carcinoma seemed to be a carryover from a previous case, and some squamous differentiation is always somewhat subjective. Interestingly, this was a borderline case between PT2 and PT3, but 96% felt it was PT2. As a result, it was scored, and PT3 was scored half marks. The next case was a TURBT. We're told the tumor was pancytokeratin, GATA3, CK7, P63, and CK20 positive, but it was negative for Pax8, Vimentin, racemase, inhibin, CA125, and CEA. This is what it looked like. Many chips of these clear cells with focal areas of slightly more squamoidy appearance. But the majority was clear. Some people would do immuno. So it looked very nested in paraganglioma, but it was pancytic keratin positive. Some people would like to do a PAS and a PAS-D to look for glycogen and exclude a lipid-rich variant. Focal squamous differentiation and clear cell change. Some people would do molecular studies. Some people say that they couldn't see CIS, and others thought there was CIS. And this was a clear cell glycogen-rich urothelial carcinoma, and 92.5% put this diagnosis. And it was felt that we could score this, even though it's an unusual appearance. You can get clear cells with lipid-rich. Now, unfortunately, number 3, the urothelial carcinoma, has slipped in, and there was no way that we couldn't disagree with this, and it scored a mark. But in future circulations, we will add it to no special subtype. We were learning in the morning presentation that the subtypes do now have prognostic indications associated with them. So we'll remove this diagnosis and change it to no special type. And then the adenocarcinoma was deemed to be wrong. Nested, as we previously discussed, has low-grade appearance with well-defined nests infiltrating through, and this is deemed to be incorrect, but scored half marks. And a plasmacytoid urothelial carcinoma has single cells or sheets of single cells with a plasmacytoid appearance, but not this clear cell. So morphologically, this was not correct. These have a very bad prognosis. And here is a reference. And the importance is that PAX8 was negative, although in this one they had focal to extensive. We need to exclude the possibility that this was a metastatic clear cell renal cell carcinoma. The next one was an 85-year-old suspicious growth throughout bladder, not typical of TCC, 4 grams. Again, this was challenging as a digital slide. There was a lot of material to look at. You see normal urothelium here, and there's just an ulcer and sheets of histiocytes, and in some areas, Michaelis-Gutmann bodies could be seen. Some people would like to do immuno, as they're worried there was a malignancy. And previous cases of this, we'd included a von Koster stain, and we had a very high agreement. So by not including this, it caused some anxiety. I really struggled with this case using the virtual image. I know that if I'd looked at it under my microscope, it wouldn't have been a problem. This is because I don't use digital images routinely for diagnosis. Fortunately, I lighted on a Michaelis-Gutmann body just in time, few. But it does beg the question as to whether being assessed by digital images, if you don't use them routinely, is an accurate assessment of diagnostic acumen. Some people would worried about sarcomatoid. I was suggesting that we crop the images to make them smaller, but I think actually what the take-home message is that we don't include a large number of slides with a large number of amount of tissue on them in a single circulation. But people should allow more time to look at these digital slides than they had done in the glass, and not do them all at the end. So we had a high agreement. On this case, it was deemed to score. But in the previous case where we scored the inflammatory conditions altogether, we felt that they were morphologically different. So the polypoid cystitis, the eosinophilic cystitis, and the interstitial cystitis did not have these appearances and were deemed to be incorrect as well. The next case was a 40-year-old female, and it was a renal biopsy. We were told they had tuberous sclerosis complex and a 43mm left renal lesion. This was a single core with some fragments. We were provided with a CK7, CD117, and Vimentin, but we were told that it was PAX8 positive and cathepsin K negative. And this is what it looked like. This was muscle fibers, and the tumor is at the top. You can see some loose stroma here, with some single cells. But the majority look like this, with prominent vascular channels, monomorphic nuclei, and eosinophilic cytoplasm. No prominent halos, no binucleate forms. The Vimentin was negative. The CK7 was strongly positive throughout. And this is critical, but the most critical stain was the CE117, which just highlights a few mast cells, but there's negative staining throughout the tumor. Some people, 16 felt it was not suitable. Some people seek second opinion. People felt it was a chromophobe RCC, eosinophilic variant. Could this be a hybrid tumor? The immuno would point to being a lot. It's a tiny sample. Rare tumor needs second opinion. And this is not typical of a chromophobe negative staining. Oncocytic neoplasm NOS is a lot more immuno. I mean, the oncocytic renal, but immunomorphology favors a lot. Low-grade oncocytic tumors, distinct entity, and they're describing this. And then someone felt it looked like benign liver tissue, but there were no ducts. So the correct diagnosis was a low-grade oncocytic tumor. 63%, well, 64% had put this diagnosis. But the Royal College of Pathologists recommends using the term oncocytic renal neoplasm when you come across a needle core biopsy. You would probably call it an oncocytic renal neoplasm favoring a low-grade oncocytic tumor. It was highlighted that the low-grade oncocytic tumors are not a WHO diagnosis. It's included in the oncocytic tumors, but it's not a defined diagnosis as such. And it's partly because the name is mixing a grade and a morphological type. The critical to the diagnosis is the CD117 being negative, which is not the case in a chromophobe. I suspect eosinophilic chromophobe, if people go back to these cases and do a CD117, they'll find that it is one of these tumors. The important thing is that it is not an oncocytoma because the CK7 was strongly positive. And that is a critical diagnosis given the needle biopsy. It was felt that the first two could be merged together, which gives agreement of over 80%. Chromophobe scored half marks. Renal cell carcinoma NOS, again, half marks. And then some of the other variants on voting scored half marks, whereas some of the other variants, we were told that it was cathepsin K negative, would exclude AMLs. And obviously, from the point of what the next stage was, it was important not to call this an AML. The oncocytic papillary, there were no papillary areas in the lesion at all. And I think it was the confusion regarding the CK7 positivity. So moving on to the prostate cause, we sent a survey round prior to this circulation to ask people about how they would score the grade groups, because this is causing some anxiety at these meetings. And we gave them various options, and realistically, slightly more people felt that they would do the ±1 grade group. But also some people would do it by case and based on management. And some people would like the participants thing. So we came to no real conclusion as to what we would do. So we felt that the participants meeting with some sort of emphasis based on management should be used as a preferred way. So the first case, AE13, was a male, 65, with a PSA of 3,000. We're not told that he had hormonal therapy prior to the biopsy. This should always be sought in. That history should always be sought out, as grading can be affected by the hormones. And here's one of the two cores. Both showed very similar sort of areas of high-grade tumor in sheets and single cells. Some intraductal proliferation you can see here. You can see the single cells. This appearance with a prominent basal layer does suggest hormonal therapy. So we would do immuno. There are not many comments. Some people would do NKX 3.1. Some people would do neuroendocrine markers. This is not recommended by the WHO in a hormone-naive person. And some people would do immuno to rule out an introductory component. But I think at this grade and stage in the PSA of this, an introductory component is of no real relevance to management. We all agreed it was cancer, some with an introductal, some with an AIP. So it was all deemed to score 1. The majority of people felt that it was grade group 5, with a small number of people grade group 4. So these were deemed to score correct. This is all, from the point of patient management, they're treated roughly the same. So let's move on to the AI system. This circulation, we used IBEX. It's upgraded since the last version we had. You load up the cases, you can see the ones which they think are benign are blank. Cancer is in red. Yellow means that it's suspicious for cancer, but not definitely cancer. And hoping this is playing. So you click on the slide, let's open it up. And it uses a heat map system. So you can see on the bottom that red is high probability and blue is low probability. So the red areas, it thinks that's where the cancer is. We're on the cancer part of the algorithm. You can toggle it on and off with the space bar. And here's the tumor. And then going on to the Gleason score, red is Gleason pattern 5, blue are the lower grades along the spectrum. Again, toggling it on and off. And it's assigned it a grade of 5 plus 4. You can go on to perineural invasion. Again, it's spotted an area here. It's in blue, so it's not particularly certain that it's perineural invasion. Again, toggling it on and off. And we can have a look at it a bit slightly closer. And that's the bit it's picking up. It does look like a nerve, doesn't it? So it's picked up some perineural invasion. It'll calculate the tumor length, the tissue length, and the tumor length. And it's populating. You can see it populates these boxes. It gives you a length here, and you can adjust it in here to what you think it should be if it's different from that, or you can just click on the acceptance thing and it will move the value across. You can look for inflammation, and you can accept the tumor length. And once you've done all that for the specimen, it's generated. It will generate a report. Just you can add comments to the bottom, add your comments. You can see I'm doing this at the bottom down here, putting query hormones. And once you've done all that, you can go to a case report. It generates this case report with all that information you've added. And then if you have it integrated to your limbs, this information will go into your limbs. And they're using talking points to be able to integrate with the limbs system. So moving on, the next case, a male of 73, PAREDS 4. This is from the left lateral base, this biopsy. And we're given a 34 beta and a P504S. And this is what it looked like. Core of tissue with some activity going on here. You see at this power, got clusters of basal cells towards one end, a cribriform architecture with some material in the middle, but not definitely necrosis, rather monomorphic nuclei, and a prominent basal layer, but definitely cribriform. The racemase highlights the lumen, and the 34 beta shows a strong staining of the basal layers. Some people wanted another opinion, more levels. Presence of basal layers, suspicious, insuspicious and benign foci, mimic, pin and clear cell cribriform. Tuber has hypernephroid, clear cell pattern, large cells. Would favour a diagnosis of intraductal. There was necrosis, intraductal. People were thinking about intraductal, but others also thinking about clear cell cribriform hyperplasia and pin. Some people felt it was not quite right to call pin because it was too complex, so they called it AIP. And then this person plumped straight for intraductal cancer. And you can see that there was a split between 46% felt it was benign, but others felt it was between the pin, suspicious, and some people felt it was intraductal cancer with no invasive component. So this was an educational case. It was a clear cell cribriform hyperplasia. We sent the images around to the experts. Jonathan Epstein felt it was an example of a clear cell cribriform hyperplasia, predominantly seen in the transition zone, and we're told it was a base biopsy, can be sampled. In contrast to AIP and DCIS, there is no cytological atypia. Prominent basal cell layer in some of the glands is also typical. And I asked him about what about the racemase. He wouldn't factor that in. And then we stressed this prominent basal layer. They're not a feature of AIP and DCIS. And I showed him our diagnosis and he says, thank you for follow-up. AIP is causing lots of problems for pathologists and neurologists in the USA as well. Other people agreed it was clear cell cribriform hyperplasia and it was looking benign, strongly suggest. And the Gleason grading was not scored. So to go on to the AI for this system, you can see it's picking up this area, but it's highlighting it in blue, which means it's low probability. It hasn't Gleason scored it because it doesn't think it's necessarily cancer. And it's moderately suspicious that it could be PIN. Again, that's low perineural invasion, didn't really see anything about that. And it's really not picking up anything. So lots of inflammation and a bit of atrophy as well. You can see these scales on this side are over to the right-hand side. And the bit that it thinks it's PIN is this area here, which I'm not particularly convinced about. And it's picking up some areas like this. You can actually see the prominent basal layer here, this little nodule at the edge. It's flagging as a medium likelihood. So it'd make you look at these areas and think about them. So the next case was AE15, a male of 62, LICA 3, 2 cores, no immunohistochemistry was done. And it's pretty obvious, even at this low power, there's a bit of something action going on here. This is what it looked like. There were some sort of little papillary bits in it, not true glomeruloid. There was some suggestion of fusion here, but it was quite subtle. A vast majority Gleason pattern 3, some poorly formed areas. Looks like glomeruloid morphology. Other people thought there was some solitary cells and cords, and they had graded it much higher. Everyone thought it was cancer, apart from one person. I suspect that was a typographical error. And in the Gleason grading, majority, 80% thought it was 3+4, with some people, 13% thought it was grade group 1. And the participants in the meeting decided to score these 1, but this was felt to be an outlier somewhat, 16 people, and would have had a clinical impact. And as a result, they were scored half marks, and then grade group 4 was deemed to be wrong. And the AI system, you can see it's instantly picked up this area here, which is the tumor, another area here, and a blob at the other end. The red being high probability. I'm just doing the tumor length here. You can adjust the tumor length to whatever you think it actually is. So the Galen system uses a system where it adds all the bits together, deleting the benign bit between them. But you can adjust that yourself, or they can set it up to do it any way you like. But this is what it's set up at the moment, which is the typical American system of measuring the tumor. And the Galen system had graded it as 3+3. So we did a survey before this circulation, of which 142 full members replied. And it's clear that the online system is more convenient to everybody, but some people prefer the physical, some people prefer the mix, but the majority prefer the online system. So as a result of this, we'll carry on doing 1 online system a year and 1 mix of 1 physical meeting, but whether we do a hybrid meeting is still up in the air. We asked them whether you liked a webinar style or a standard Zoom meeting. There was a slight preference to webinars, which we prefer. And interestingly, 30% of people had accessed the YouTube video of these participants meeting, and hence we're recording this one after the meeting. So what's the future? We're going to go 100% digital for the next circulation. The membership fees will be equalized as well. And the digital images will be hosted on Oxford as well as Leeds. And can I stress that the Leeds does slow down if everyone accesses the images at the same time. So everyone leaving these EQA circulations to the last minute will have problems because it will slow the system down. So it's worthwhile doing a few cases at a time, and we'll try and minimize the numbers with large TURBTs or TERPs in them. Don't forget, the new WHO is published in paperback, but the online version is excellent, and it has useful links directly to the papers involved. We do provide this renal tumor table, which has examples of the entities and then direct links to EQA cases. So the nephroblastoma and the juxtaglomerular tumor will be added to this in the near future, but the main common ones will be there. And the other thing which you need to remind people about is that there's the pathology portal, which is being supported by the RCPAF. This is a training area, and they are keen for a GU editor to get involved. And this is the email address. So this is an access for training and for consultants as well. So there's not much urology up there at the moment, so we need more urology content. So anyone interested, please contact them. So our acknowledgements, thank you for the EQA Secretary, Mick Daniels, the Leeds and Oxford posting the images, and IBEX for allowing us to demonstrate the AI.